Dear colleagues, welcome to another e-learning session with the Synapse. With us today we have Dr. Susan Aquilina, a consultant dermatologist with whom we shall be discussing urticaria. Dr. Aquilina, thank you very much for accepting our invitation for this session. Urticaria, also known as hives or nettle rash, affects up to 20% of the population, and it's a condition that several healthcare professionals working in different settings, starting from the pharmacists in community pharmacies, doctors and dermatologists, meet throughout our practice. Dr. Aquilina, how would you define urticaria, and how is it diagnosed and differentiated from other conditions which present with similar symptoms?
So, urticaria is quite an easy condition to diagnose. It presents with typical wheals. These are raised plaques that are not scaly, red, and usually itchy. And the important thing about them is that the rash is migrating. So each wheal will last less than 24 hours. So if a patient had to encircle a wheal with a pen, they will notice that within 24 hours there is no trace of that wheal. Part of urticaria is also angioedema. So some patients who present with urticaria will also have deeper swelling. While urticaria tends to affect the more superficial layers of the skin, angioedema is affecting the deeper layers. And these patients will present with swelling of their lips, of their eyes typically. So angioedema can be a part of urticaria or can also happen on its own. Patients who have angioedema presenting on its own, then you have to consider some conditions like hereditary angioedema, ACE inhibitor-induced angioedema, or also idiopathic angioedema. And when we talk about urticaria, the duration of the rash is important because we divide patients who have urticaria on and off, but occurring regularly for less than 6 weeks as acute urticaria, and urticaria lasting for longer than 6 weeks as chronic urticaria. And this time frame has been chosen as most cases of new onset urticaria will have resolved within 6 weeks. So only 1/3 of cases with new onset urticaria will last longer than 6 weeks.
Is there a risk of escalation to anaphylaxis? If that is the case, what are the red flags that both patients and healthcare professionals should be on the lookout for, and what advice should we give to the patient?
So patients presenting with acute onset urticaria should be asked about some symptoms that might suggest that anaphylaxis might occur. So urticaria and angioedema can form a part of anaphylaxis, but anaphylaxis is reflecting an acute generalized reaction that is also involving the respiratory systems and the cardiovascular system. So a patient with urticaria and possibly angioedema should be asked whether they have symptoms of throat tightness, shortness of breath, chest tightness, difficulty with breathing, cough, nausea, loose stools, abdominal pain. And if they are experiencing one of these symptoms, then anaphylaxis is happening. And these patients should be treated as soon as possible with a shot of adrenaline, which is why patients who have already experienced an anaphylactic reaction are prescribed EpiPens. They should be instructed on how to use them, and that they should use them at the first symptom that suggests anaphylaxis might be occurring.
Thank you very much for that overview. What are the commonest known causes and triggers of urticaria?
So when talking about new onset urticaria, we can think of 4 broad causes or triggers. So infections, drugs, food, and insect bites. So if we think of infections in a pediatric series, they had found that 80% of cases of new onset urticaria were actually due to infections, commonly viral infections. Bacterial infections may also be triggers, as may parasitic infections. Then if we move on to drugs, a number of drugs may cause urticaria. Some will be IgE mediated, some will happen through direct mast cell activation. Penicillins and cephalosporins are the commonest triggers of an IgE mediated urticaria or angioedema. narcotic drugs, vancomycin, muscle relaxant, radio media used in radiology. All these may cause urticaria through a direct muscle activation. Non-steroidals are common drug causes as well. And non-steroidals may trigger urticaria in patients who otherwise do not have urticaria, or may also aggravate patients who are having a chronic urticaria. So patients with chronic urticaria in general are advised to avoid non-steroidal anti-inflammatories. And most of these drugs will cause urticaria or angioedema within a short time frame. But this is not the case with ACE inhibitor-induced angioedema. So it is important to note that many patients get angioedema episodes after many years of uneventful use of an ACE inhibitor. So it is important that any patient who presents with angioedema without wheals, if they are on an ACE inhibitor, this ACE inhibitor should be stopped. Otherwise, the attacks may become more frequent and more severe, and fatalities have been reported as well. Finally, food is a very important cause of acute onset urticaria. In children, the commonest triggers will be milk, eggs, tree nuts, peanuts, soy and milk, while in adults the commonest will be tree nuts and peanuts, and also fish and seafood. So commonly these reactions are IgE mediated, so they happen usually within minutes, typically within 60 minutes of consumption of the food. In some cases, it may be, the reaction may be IgE mediated and the reaction may take longer to develop. But typically when a patient is consuming a food that is causing urticaria, the reaction happens within 60 minutes. Also, the reaction is reproducible. So if a patient is allergic to a food, every time they consume that food, they will get a reaction. Patients who wake up in the morning with urticaria or angioedema and have not consumed any food in the night, in that situation, food allergy as the cause of their urticaria may be excluded. Then when we come to chronic urticaria, the situation is very different. Chronic urticaria is not considered an allergy. So when doctors or health professionals tell patients who are suffering from chronic urticaria that what they have is an allergy or what they have is an allergia in Maltese, they are actually misleading the patients. And these patients are going to be looking for an allergic cause for their chronic urticaria when there is none. In fact, most cases of chronic urticaria are thought to be of autoimmune origin.
Do physical factors such as the heat, cold, and pressure cause urticaria? Can they cause urticaria?
Yes, so we can divide urticaria into chronic spontaneous urticaria, where there is no physical trigger, or inducible urticarias. Inducible urticarias form about 20% of chronic urticaria cases, and there are various triggers in this situation. So a patient may be asked, is there anything that you can do to trigger the wheals to bring on your urticaria? Some will say, if I scratch my skin, I will get an urticarial wheal, and this is called symptomatic dermographism, and is the commonest of the inducible urticarias. Some patients will say, if I go for a jog and I sweat, I'll get urticaria. This is called cholinergic urticaria. Some patients will notice that pressure can trigger urticarial wheals. So for example, if they wear a tight belt or they're carrying a heavy bag, when they remove the bag under the strap, they will notice urticarial wheals. This can be a big inconvenience for patients. So for example, a cleaner who is wringing a cloth might notice that her hands swell up after doing this activity or after clapping, for example. Also after sexual intercourse, some patients will complain that their genital area swells up. Delayed pressure urticaria is one of the hardest forms of urticaria to treat because they tend not to respond so well to oral antihistamines as the other urticarias tend to respond. Then some other physical triggers may be cold, and the patient may notice that if they are in a cold wind, their face swells up, for example, or if they jump into a pool of cold water, they might get urticarial wheals. This may be severe enough for them for it to result in shock, so patients should always be careful in this situation. Heat is often aggravating urticaria, possibly through vasodilatation. Solar urticaria is not a common form of inducible urticaria. Polymorphic light eruption is a much commoner photodermatosis. We see polymorphic light eruption quite commonly in the beginning of summer when a patient who has not been exposed to the sun gets a rash on the first severe sun exposure. It's important that patients are educated about the possible triggers so that they may avoid them.
When would you consider testing to identify possible causative agents, and which tests are available and which are their respective roles?
So patch testing is not a form of testing in patients who have urticaria. Patch testing is a test that is used in patients who have chronic dermatitis. So patch testing is used when there is a suspicion that a chemical that is coming in contact with the patient's skin is causing an eczema. So patch testing is a test that is used for patients who have eczema, not urticaria. In patients who have urticaria, when you're trying to find what could be causing their urticaria or aggravating it, the history is the most important part. So unless there is a suggestion from the history, then ordering blind tests to see if what possible food could be triggering the patient's urticaria does not make sense and ends up being costly for the patient, and the patient can get misleading tests. So because here we are talking about IgE-mediated food reactions, it would make sense to perform an IgE test to a particular food if the history is suggesting this reaction. So for example, a patient might not normally consume seafood, but might have attended a wedding, eaten some seafood, and got an urticarial or angioedema attack. In that case, yes, it would make sense to carry out IgE testing to prawn, to fish, to whatever seafood the patient might have consumed. And if this test is positive, it's corroborating the history. However, it doesn't make sense to test for seafood in patients who have never had problems with consuming seafoods. Think that IgE testing or skin prick testing will both have some false positives and false negatives. So it's important that the interpretation is done in the correct clinical context. So it's pointless testing unless there is a lead from the history. Then when it comes to patients with chronic urticaria, allergy to food IgE allergy to food does not play a part. So patients with chronic urticaria do not need IgE testing to foods unless the clinical history somehow is very suggestive. Patients with chronic urticaria normally have baseline blood tests, including CBC and ESR or CRP. Some clinicians will also order TSH because a significant percentage of patients who have chronic urticaria will also have autoimmune thyroiditis or a family history of thyroiditis. But in some patients who have chronic urticaria and who are responding very well to oral antihistamines, some clinicians will opt not to test at all.
Moving on to treatment and management, what are the treatment options available for urticaria, and how does treatment vary according to severity of the cases?
So part of the treatment is to establish obviously the correct diagnosis, to establish that the patient is not having an anaphylactic reaction. But the first line treatment in patients who are having urticaria is oral antihistamines. And normally second generation non-sedating antihistamines are preferred. There might be a place for sedating antihistamines if a patient is very agitated with the urticaria. Having a sedating antihistamine might help in that situation, but we don't encourage taking sedating antihistamines on a long-term basis because these can affect sleep and they can affect the cognitive function of the person. So all international guidelines will recommend that the first line should be an oral antihistamine that is non-sedating or is of a low sedating potential. So most patients will do well with the standard licensed dose, which would be 1 a day. Some patients might need updosing, so they might need to increase the dose to 2 a day or maximum to 4 a day. And again, most patients will do well with this. Some clinicians would recommend to change antihistamine if one doesn't work well, and I think that that is a fair thing to do. However, it's not doing a patient who has severe urticaria, it's not being fair to the patient to just keep asking them to change from one antihistamine to the other. It's called playing roulette with the antihistamine. So if a patient is not responding to a few oral antihistamines, not even to updosing, the patient should be referred for a stronger treatment. Sometimes oral steroids are used. So oral steroids normally are used for cases of acute urticaria with angioedema, where the patient is very distressed, or where the patient is not responding well to oral antihistamines. Normally, we suggest that the courses of oral steroids are limited to 5 to 10 days. Because when the patient will stop the antihistamines, the oral steroids, the urticaria will recur. And even patients who are given oral steroids should also be given oral antihistamines. It's very important that patients with chronic urticaria are not maintained on oral steroids, because normally these patients would need relatively high doses of oral steroids, like 20 milligrams a day. And of course, we all know the side effects of long-term steroids on the person. So what do we do with patients who have not responded to high-dose oral antihistamines or a 10-day course of prednisolone? Then the next options would include ciclosporin, oral ciclosporin, which, although it sounds like an aggressive treatment, it's safer for patients than being on long-term oral steroids. And normally these patients are relatively young, and cyclosporin sort of can cause side effects on kidneys and hypertension, but a lot of our patients are young and have no kidney disease and no hypertension. So cyclosporin is one option. Another option is a new monoclonal antibody called omalizumab. Omalizumab is a monoclonal anti-IgE, and this is injected into the patients every 4 weeks. And the results are very good. It is very safe. The big problem we have with it is that it is expensive. Some other options that are used would be dapsone, but dapsone may cause a drop in hemoglobin, so it might not be appropriate for all patients, and definitely you need to exclude G6PD deficiency before that. Sometimes montelukast is used, some other treatments, depending on the case. But most patients with urticaria, with chronic urticaria, should have good control of their condition. Keep in mind the impact that chronic urticaria will have on a patient's quality of life, the unpredictability of the flares. They might wake up with a swollen eye, swollen lip. They really can't go to work if that is happening, apart from the itch. So it's important that patients are treated adequately.
In which cases should patients be referred to dermatologists?
So two main situations. One, the first would be a patient with chronic urticaria who is not responding to updosing with oral antihistamines. And the second situation is if the urticarial wheals are lasting longer than 24 hours. In that case, the alternative diagnosis of urticarial vasculitis has to be considered. Patients with urticarial vasculitis will have wheals similar to urticaria, but in this situation, the wheals will last usually for 2 to 3 days, and they might leave a faint bruising, whereas in patients with urticaria, the wheals just vanish without a trace. Also, patients with urticarial vasculitis might complain of pain rather than just itch. And they may also have some systemic symptoms like fever and joint pains. These patients should all be referred to a dermatologist.
Dr. Aquilina, thank you very much for a very informative session on urticaria. As I said in the introduction, urticaria is a symptom that many of us healthcare professionals working in different sectors encounter frequently, and I am sure that this session was therefore very useful for all of us. I invite you to complete this e-learning experience by completing the set of multiple choice questions attached to this session. Following completion of the multiple choice questions, you can download your certificate from the Synapse e-learning website. For more e-learning videos, I invite you to visit www.thesynapse.net/CME.